Hello everyone, I'm Dr. Mrunal NC, Radio Diagnosis resident from KIMS Bhubaneswar. Today I'll be presenting a case series on imaging of hemangioblastomas. Hemangioblastomas are benign vascular tumors, mostly found in the posterior fossa, particularly the cerebellum. Around 60 to 70% are sporadic, while 30 to 40% are associated with von Hippel-Lindau syndrome. They usually present between 30 and 50 years of age. MRI is crucial for diagnosis, with a classic feature being a cyst with an enhancing mural nodule and internal flow voids representing feeding vessels. The aim of our case series is to evaluate the role of imaging in diagnosis of hemangioblastomas and to characterize the various morphologic types of intracranial hemangioblastoma on MRI in correlation with histopathology. We retrospectively analyzed imaging findings of 4 patients, 3 of which were females and 1 male, with surgically proven hemangioblastomas over a period of 2 years, from 2024 to 2025. All patients underwent MRI on a G Sigma HTXT 1.5 Tesla scanner. Our first case was a 46-year-old female with headache and vertigo. MRI showed a large lobulated non-enhancing cystic lesion with an enhancing mural nodule in the left cerebellar hemisphere. Note the prominent T2 flow voids within the lesion representing feeding vessels, an important imaging clue. The second case was a 42-year-old male presenting with headache and vomiting. MRI showed a solid cystic lesion with T2 flow voids in the right cerebellum and an enhancing solid nodule in the left cerebellum. Additionally, a similar enhancing lesion was seen in the spinal cord at the level of C5. Given the multiplicity and spinal involvement, a diagnosis of von Hippel-Lindau syndrome was established. The third case was a 14-year-old female with head reeling and visual complaints. MRI revealed a well-defined peripherally enhancing cystic lesion with multiple T2 flow voids in the vermis. Fundus evaluation also showed a retinal angioma with retinal detachment. These findings confirm the diagnosis of VHL syndrome. The fourth case was a 40-year-old female with headache and vertigo. MRI showed a non-enhancing cyst with mural nodule in the left cerebellar hemisphere with T2 flow voids. Multiple similar enhancing lesions were seen in the spinal cord, dorsal pons, and bilateral cerebellar hemispheres. Again, this was consistent with VHL syndrome. In our series, all cases showed T2 flow voids, which is a very characteristic feature. Most lesions were located in the cerebellum, 4 in hemisphere, 1 in vermis, followed by spinal cord in 2 cases and retina in 1 case. In terms of morphology, 2 were non-enhancing cysts with mural nodules. 1 was solid with internal cyst. 1 was cyst with wall enhancement. 3 of our 4 cases were associated with von Hippel-Lindau syndrome. Hemangioblastomas are benign WHO grade 1 tumors occurring sporadically or as part of VHL syndrome. They show distinct morphologies: cyst with mural nodule, solid with flow voids, cyst with wall enhancement, or solid with internal cyst. MRI is the most sensitive modality as it not only depicts morphology but also demonstrates flow voids, a key differentiating feature. Microsurgical resection tailored to tumor morphology remains a treatment of choice with generally favorable prognosis. However, recurrence may occur in 8 to 16% of cases, sometimes with a different morphology than the original lesion. In summary, hemangioblastomas are benign but highly vascular tumors. MRI helps in diagnosis and surgical planning, while flow voids being an important feature. Multiple lesions may indicate VHL syndrome. Complete surgical resection is a treatment of choice and generally leads to a good clinical outcome. These are my references. Thank you.